Here
Windows. Okay, whoa, 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 whoa.
we are. Oh, you're closing your windows? Hello, Lisa.
Oh, I'm here. I
Hello,
found the
hello,
window.
Melissa.
I was like in the middle of like trying to close all the other windows so we don't like bork the connection. Here we are. We're
Oh,
live.
Bork the connection. Here we are. We are
Yeah.
live. So,
That's a
Melissa,
dated
what's
reference
going?
to Robert Bork. Don't Robert Bork? Robert Bork? That was for
I don't know.
Richard,
I
Robert,
don't know,
Richard, one of those
Lisa.
guys. Very
You're
dated
older than
reference. I'm
me.
very old. I'm an old person.
Yeah, I don't know. You're much older, so I don't know.
Ancient.
Hey, Melissa, what's going on? Who do we have on today? What's happening? Other
Hi,
than the uterus
everybody.
thing.
Happy Friday. Today we have Krishna, who is a visionary leader in the healthcare sector. He's currently serving as the Senior Vice President of Health Transformation and Provider Adoption. I've had the pleasure of speaking with him a few times. He's amazing. He's got
A
over
company?
at Horizon Blue Cross. Okay. Did you hear me? I don't know.
Yeah.
My sound's going in and out. Sorry.
No, go for it.
Sorry. Anyway, he's got over 2 decades of experience. He's had significant contributions to advancing value-based care and improving healthcare delivery, and his commitment to diversity and inclusion adds a unique perspective to his professional insights and should be an amazing guest for today's show.
I love it when we have visionaries.
Yes, they're amazing. Also,
Melissa, he is from Blue Shield of California.
I was
To
waiting
be
for
clear,
it.
my friend.
Slightly different. Blue Shield of California, big, very important, local California, San Francisco.
Local in California is basically national in the US.
I got it. I got it. Sorry, notes bad.
Okay.
Okay. We also have buckle up, Buttercup. Yes, I will, Michael. Thank you so much. In addition, we also have Dan Nardi, who is the CEO of Reimagine Care. Am I saying that right? Is that properly? Like I'm doing right now, just making sure.
We're so mean. We're so mean to our volunteer, amazing employees.
We're trying here, okay?
We're the worst. We're the worst non-bosses.
Yeah. Anyway, he's a pioneering provider of home-based cancer care services that is just transforming the way patients receive treatment in the comfort of their own homes. He's also a pioneering provider. I wrote that twice. With 23 years of experience in the digital health sector, he's an active board member and advisor for several nonprofits and startups, and he showcases his commitment to fostering growth and innovation in the healthcare space.
That's sweet. Visionaries.
My good.
Nice.
I did it.
All right, you freaking crushed it, Melissa. You did it. You did it. Yeah, you know, it gets better every time.
Every time.
We love you.
It's like, I try.
Okay. On we go. Where'd she go? We ought to kick her off. All right, Lisa. All right. Oh, right. Okay. So here's our news show. Here's you guys. We have news as usual. So here we are flying an airplane. It is a skill that we both possess, clearly and obviously. But yeah, so we announced on the internet. What did we announce, Lisa?
We are going to be attending as the first fake/real journalist to ever do a live, unscripted, unrehearsed show at Epic's big user group meeting next week in Verona. I have never been. We are also the first real/fake/also still real journalists doing this type of thing. It's us. They're breaking the mold with the Health Tech Talk Show at Epic UGM. No one has told us what we can say. No one has told us what we can say. We can say whatever we want, which is what we always do. And we are flying ourselves there. So all good. Yeah. Wow.
We're going to be there.
Exciting.
Yeah, it's great too because I know everybody, I think we had some comments mostly from a friend of the show / arch nemesis, Matthew Holt, who said that we've been assimilated. But to be clear, we even said, are you guys going to make us say stuff? And they were like, no. So it sounds like, I don't know if they're going to stop us. Like, I know, like, you know, telling us what we can say is one thing, but like stopping us,
shut off the internet. They'd have to shut off the cell networks.
You could shut off the internet.
We're broadcasting live from StreamYard, this current platform, and as long as they have like 5G, I assume in Verona or whatever, like we'll be live.
No, I don't know, but I think it's going to be great. So we've heard all kinds of awesome things. We're gonna interview a bunch of people, but one of whom is a repeat friend of the show, Dr. Patrick McGill, Chief Transformation Officer of Community Health Network. And we met some other friends on the internet this morning who said they're going, and they're also going to stop by. I'm not sure. It's unclear to me if we were allowed to just invite more people, but we just told everyone to show up. So
no, listen, we've never had a plan for the show. So if it's a live show, like at a conference, anything could happen. Anything could happen. This is not exactly a conference, but it's like that because so many different people from different organizations and companies are coming. So you know what? There could be some unannounced guests. That's all I can say.
That's all I can say. And also, Michael Marchant, who is our favorite unpaid correspondent, also our only unpaid correspondent, but still the same. We would love him the most if we did have more. He is like the chair of the Care Quality Steering Committee. He's like basically a celebrity there, according to what we know. Like so that. He's also going to stop by, and he's doing some like on the street interviews. And we don't know. The point is, it's going to be great. We're excited about it. It's going to be great.
Yes.
Tune in 3 p.m. Eastern Central Time on Tuesday. Yep, Central Time. Yeah. Okay. Exciting news. So some of our friends got acquired this past week. Some of them also got money. So that's great. So Care AI, which is like super cool, as you can tell, AI type of company. This is our friend Bruce Brandis is still the president. I assume he is still the president. I don't think he cashed out and walked out the door yesterday, but this is his company. We are super excited for him. I did have a heart drawn around his face, but it didn't come through. So congratulations, Bruce. We hope you're a bajillionaire and that you keep saving everybody's lives with the AI. Congratulations.
Same.
Oh, these are our friends, Lisa. Not our little friends. I shouldn't say that because they're actually taller than us. Photon Health. The Photon guys who are crazy and throw great parties. As everybody may remember from Health last year, they won our Best Party of Health award, and they continue to be pretty wild. So they raised a $9 million round they announced this week. I forget who all was involved, but I know that Flare Capital was one of the lead investors. So
not surprising. Congrats, guys.
Yep. Basically, they are going to disrupt. I think some of the headlines, like the Fortune article, I only read headlines, Lisa, but it said they were going to disrupt the monopoly. Yeah, I feel like they're playing off our show from a few weeks ago. I don't know. I am self-important, so that's what I think.
It's great.
Oh, this is your story.
Oh, yeah. This is something I pulled off of Health Tech Nerds. Shout out to Health Tech Nerds. They're obviously this is Inc. This is not Inc. This is not Forbes. This is Inc. Anyway, when a business magazine sort of rates you as something like questionable always, but they have decided that Vitalize Health is America's fastest growing private company. Vitalize Health is a ACO Reach company. So they are an ACO enablement company, but because of the structure of ACO Reach, previously known as direct contracting, they're actually like taking in the money from CMS. This is a CMS ACO, a Medicare ACO, and they're managing the money in and out and the risk. And it's a little iffy if I would really call Vitalize Health or an ACO Reach company the fastest growing private company in America. I think that if you kind of dig in there a little bit, you'll see some questionable numbers, gross, net revenue, all that good stuff. So congrats, guys, but also I'm not sure that being a intermediary for the government to providers is necessarily the same as sort of building and developing and selling a product and having that grow really fast. Question mark. Me.
See, big question mark. That's what I'm talking about. Math is not real.
Math is a little bit hard. In this case, there was some fun math in this one.
Yep. Anyway, the point is be wary of the media, including non-real media outlets like us.
And don't ever be ranked the Forbes 30 under 30 you're going to prison. That's like Forbes 30. It's like known to be like a Forbes 30 under 30 to prison pipeline. That's what it is. Don't ever do it. Or don't tell your PR people to not put you up for Forbes 30 under 30. It's not good. We should do
an episode where we interview non-in-jail, non-incarcerated people on that list and see what happened.
Nice.
Like if they had good lawyers. That's a good idea. Future show idea. Okay, today, exciting things happened in the world of interoperability, which we know all 7 of you care about very much.
Yeah, and also shout out to Ben Leonard, whose email I completely ignored. I'm so sorry, Ben. It looks like he wrote a great article anyway. Sorry, Ben.
He didn't call me, Lisa, so it's fine. Yeah. Anyway.
It's amazing.
What happened? Lisa, what happened?
Well, this is the continuation of the story we've been sort of telling in bits and parts here. Basically, Carequality has, taken a deep look at their governance and their use cases and what the future is with Carequality and TEFCA. As a reminder, they are currently like parallel frameworks, if you will. And it looks like Carequality has said, we are just going to follow. We're going to make all of our use cases TEFCA use cases, and someday we might not exist. That's rereading between the lines. Is that Carequality is going to align to TEFCA until there's no need for a separate Carequality and a TEFCA, as far as I can tell.
That's what I'm reading.
That's the read between the lines here, and I mean, it's good, right? Like, why would you build out like parallel use cases and SOPs here? That would be dumb. And they've clearly said we are not going to do that anymore. And Epic has said, great, we support you per this this announcement they posted.
Cool. Yeah. I mean, this is like every comment letter I've ever written. I start out with, we applaud whatever agency. We commend
Congratulations.
You. Also,
you did your job.
We're basically moving away from amazing. Anyway, I actually think it's pretty great. It does look like they're gonna give their hospitals a lot of transition times. That's like super rad. But interesting.
But what they're saying we're gonna be live on this like by the end of the year for everybody who wants to be there, whatever. What I will say is, like, no matter what you think about Epic as this massive company with this huge business, with pretty much every single hospital, acute care hospital using Epic at this point, it's risky for all kinds of reasons. But what you can know for sure about Epic is that they want more data for their customers, for sure. So that means they, like a lot of other parties, are saying, like, how can we be part of these national interoperability networks for real this time, whatever form that takes. And then also they want to make sure that the data is secure and their customers aren't subject to a breach notification. So, lots of reasonable people can disagree about the process here, but we are moving towards a little bit more standardization. So that's
and this is an unreasonable show, Lisa. So we don't have to talk about reasonable things on here, but I do think this is the cat show of my mind right now. And like, I just want to say, like, it is. So if you go to this article, which is a pro article, so sorry, y'all, you have to pay for it. By the way, Political Pro is great. You should buy it. It does talk all about how, like, basically this all started from the.
What am I, a billionaire? I can't afford Political
Lisa,
Pro.
and I would never let you use my login ever. Right. So anyway,
what am I, but yeah, they were talking about
the Epic particle thing and how it's still not resolved, which is like kind of ridiculous, and how, like, I don't know. I actually think it's kind of awesome that Epic kind of like did some stuff here and like made some changes. I'm sure reasonable people, Lisa, would also say that wasn't totally because of Epic, but this is an unreasonable show. So we'll see what happens. I don't know. There's lots to come here. We'll see who we get to interview on our show next week and what they think about all this, because there will be actual real providers there. That's exciting. So more exciting news about United. This is more about Medicare Advantage, which everybody knows Lisa and I apparently think is the worst thing ever. But there's a multi-part series in Stat about this a company called House Calls, which is a United company that goes out and basically like finds diagnoses for people to get paid more money. And this is an amazing quote from the Stat piece that came out. It is Stat Plus. This is, again, another subscription thing. So sorry, everybody, you're going to have to pay money for it. But basically, let's turn on the gas about continuing to find ways to make more money out of American healthcare. So that's great. Also showing Medicare Advantage, how we are testing rates of artery disease. Obviously, you can see that some people are exploiting some loopholes here. And yeah, this House Calls company, like, it sounds like it might be a company where people with rotten souls go to work. I don't know. Like,
yeah,
I don't know.
Yeah, it's tricky.
I don't know who runs it.
It's tricky.
I don't know who runs it, but we should Google them and see if they want to come on the talk show. Is what I want to
totally.
Say.
Come on our show. We'll be nice.
We'll see what happens. Lisa, we're always nice. We are reasonable, if nothing else. All right. Hey, this is, you used to work at CMS. Tell us what happened.
Yeah. So, I mean, questionable as well, right? But for a long time now, as part of the Inflation Reduction Act, which has a long tail, we are finally, as Medicare, negotiating some drug prices for some of the most commonly used drugs for Medicare beneficiaries. it's good, an idea. Yes, it saves billions. People who are like really into this world were like, those are the gross prices, not the net. Again, gross and net prices. Math is hard. So they were kind of like, yeah, it's the prices are good, but they're not like really revolutionary because like other parties have negotiated lower prices than that. And there's this whole weird like money laundering situation in drugs with PBMs or with gross and net prices. So like whatever, again, math is hard. But I would just say, good, do more, keep negotiating. You're a huge purchaser. Save my tax dollars. Thank you, CMS.
Yeah. Like last time I checked, I think like the government is the largest purchaser of healthcare services and stuff. So yeah, definitely a real thing. I did read an interesting comment on Health Tech Nerds. I think it was Health Tech Nerds that this one guy was like, listen, if you squeeze one into the sausage, it's just going to pour out somewhere else. So they're like basically saying there's going to be some way they're going to, these guys are going to keep making money, which like I believe. But anyway, that's like kind of exciting. This has been something that's been going like across administrations too. This isn't just a left of center type of situation. This has been something that a lot of administrations have fought over.
It's a great idea. We should do more of it. Yay.
Let's see what happens. So this is kind of out of order, but our friends at ARPA-H, mostly what I want to say here, we have a guest that's going to talk about the future of cancer care. I thought this was cool. Also, what I really wanted to do here was comment on like y'all at ARPA-H and basically the government in general. You guys need to stop using dumb acronyms. Like this is the dumbest acronym I have ever heard.
ARPA-H, man, you guys, I love you. I love your work.
Bio for early intervention and detect. What the hell? And also, where's even the end?
I love them. I honestly like you guys. It was a cute idea, but it should probably end now. Thanks.
Like, do you think they have someone who just does this?
Yes.
They should get fired, but I know you can't get really fired if you work for the government.
No. I think I know the guy. He's really nice, but like, I don't like these.
No. Okay. Well, anyway, sorry. We're going to talk to a guest who runs a real company in cancer care. That's exciting. And then these Elion people seem to, am I saying your name right, Lisa? Do you know?
I guess
Elion. Anyway, they do some interesting reports. And so they just released this one about our favorite topic, artificial intelligence. But in RCM, which is a place that we thought it would work, so I feel like we were totally right. And it's like multiple pages. Look at all these little things. All about the RCM
I like AI denials management. Be a little more subtle. Nice. Good job, everyone. Perfect. That's what we want to do. Deny faster.
No.
We might make Krishna talk about that. Sorry, Krishna.
Oh no! Do you think he runs a company that does something like house calls or Signify or like he no, I know he doesn't run a company, but do you think they do that? We're gonna ask him. We'll see what happens.
We'll ask him. He's probably gonna end the call.
He's like, disconnect. He might drop. I think he's gonna be fine. You know, the thing is, like, also last time I checked, Lisa, neither you nor I ran an insurance company, so maybe he'll enlighten us on.
Also true.
He might school us. Anyway, so this check out this report. It's free. You do have to give them their email address, but if you're like me and Lisa, you own 75 domains and Gmails and all of them, so you can use one of those. But it is a pretty good report. We have some friends on here from former Collective Medical people who you have partied with, Lisa, including Wayne Grodsky, who is Chief Revenue Officer of Smarter DX, and then our friend Gabe Waters, also formerly of Collective, is at Evidently, and then I don't know. Basically, everyone gets acquired by Optum, so mostly they'll all be the same company in a couple of years, I think. So
totally,
we'll see what happens. Yep, I don't know this other stuff here, but and speaking of AI, more. I got to keep talking fast. The news show's long today. So speaking of AI, Kaiser announced that they're rolling out this Abridge AI thing. We love AI. Also,
shout out.
There was some scuttle on the LinkedIn, Lisa. Apparently they displaced Nabla, which was just put in about a year ago. And so the scuttle is that Kaiser picked Abridge because Kaiser Permanente Ventures is one of their funders. So
I wasn't totally clear that because Nabla maybe was also for the physician group, but it's a weird choice. Like it's a weird choice if you like just spent a bunch of money and did a whole thing and then you're like, oh, just kidding. We're going to pull that. TBD.
I don't know, but I did like the shade, the like semi-classy shade from the Nabla CEO or the Nabla founder. So that was great. Nice. Go check it out. Also, Lisa, AI is dumb.
Yeah, I noticed this. I found that the nest of the Waymos here in San Francisco a few weeks ago was very weird. And this is one of those places where there's like a nest of Waymos where they go back in the evening. And apparently they were all honking at each other all night, keeping people up because they got confused. So it was like a bunch of autonomous vehicles honking at each other in a parking lot and moving forward and backwards 1 inch. Amazing. Truly the best use of AI. I congratulate everyone
God bless
who did
it.
this.
God bless
Very
it.
bad.
God bless it.
Very
Oh
bad.
my God, amazing, amazing. And then this is the last bit of our news show, and then we're going to talk to some real guests who have real things to tell us. But Lisa and I are both moderating panels at the Health Data Palooza. It's basically going to be amazing. There's lots of exciting people going. Health Data Palooza is cool because we will be there. And we are throwing an interesting person dinner on the 16th, and you have to be registered to come.
Yeah. Yeah.
What? Oh my
That's
God.
the first step. That's the first step to being invited. It's not the only step.
Yeah.
So start
then
with
you also
start with
have
coming
to
to the
be
conference.
interesting.
Yeah.
You have to be interesting.
Exactly.
And we're collaborating with Lucas Trementozzi on who is cool
Big
enough
data
to go.
daddy.
So, big, yeah. If you're still on X, which is debatable for many people, his Twitter handle is Big Data Daddy. So, which is how Lucas originally got an invite.
He's amazing. He's amazing.
Who has a Twitter handle like that?
He's great.
Anyway, okay, all right. That's the end of this
real show.
show. Okay, on to the real show. Oh my gosh, he didn't drop off.
You didn't drop off. That's amazing. Congratulations.
I didn't like drop mic and leave. You're right.
He's like,
oh my God. Thank you for staying. Oh my God. Okay. Also, we just want to shout out to the Uncommon Bold people, right? Because we love all the guests that they pitch us. And I think, right? Am I right?
I think that this was Emphasis.
Oh shit! Emphasis Media. We love that too.
Yeah. Shout out to Sarah.
Anyway, okay, yeah.
Sarah Seguinetti.
I get all the companies in California mixed up.
It's fine.
Yeah,
it's
anyway.
just me as an individual and Emphasis and Uncommon Bold.
Krishna, thank you for still being here. So tell us what you do. Like, what you have the longest title ever.
I know, the longest title, the longest last name. So that's me. And I used to work at Epics. I'm gonna give you all the tips for navigating campus as well. So
amazing,
wonderful. I've been to probably a dozen UGMs, maybe more, but I haven't been the last few years. But it'll be fun. You'll have a great time.
We're ready. Nice. Yeah. So what do you do? It's like transformation stuff.
Yeah, so I lead our transformation efforts there. Essentially, I mean, I partner with sort of, innovators and folks to improve healthcare, whether it's quality, efficiency, access. So I lead projects like our value-based care efforts, so new models, working with providers to adopt the models and help them optimize, maximize. I do work on data exchange. I know it's a topic close to your hearts as well. So some of the work we're doing to exchange data with provider partners, being able to light up use cases in the payer side. So those are some things I work on. I'm also the executive sponsor for our Pride employee resource group. So it's like a LGBTQ focused group as well. So many efforts in health equity and furthering work here as well.
And you work with our friend Shruti. Shruti, of course. You work with our friend Shruti Kotari.
Yes, I do. She's wonderful. Yeah, she's great. And then prior to Blue Shield of California, I was at a large multi-specialty provider group. And then prior to that, I spent 8 years at Epic. So I worked with health systems across the country. So I've spent time sort of a healthcare tech provider for about 8 years, and then payer for about 6.5 years now. So
nice,
right on. So what do you think of all this United expose drama about their house calls business?
Yeah, it's interesting.
You guys do the same thing?
We don't use house calls, and obviously our members come in all kinds and want to see care delivered differently. So I'm sure we have like home vendors and home sort of care providers in the mix. Just that not everybody goes to an office or goes to a hospital, and so. Generally speaking, for visits, we try to match our members to providers themselves if we want to have a ongoing established relationship. But sometimes members do go to, home vendors like Dispatch Health and others as well in the process, just because for easy access to care.
Yeah.
All right.
Maybe not.
Yeah.
Maybe not a unified effort to upcode through house calls.
Yeah. Potentially not so shady. That's good. Excited to hear that. What do you think? Okay. Lisa, do you have real questions? Because I'm just like,
no, go ahead.
Okay.
You're going.
Okay, so we love data exchanges are like our favorite thing. What do you think of the California DXF?
I'm glad they have it. It's actually really cool to see sort of like lean in from the government in order to further exchange. And so that's been good. Like the fact that like we've got a regulator that is cares about the topic, sees the benefit. I think that part's been cool. I wish like compliance and adoption were better. Obviously, it's been super like weak overall, like from a starting point perspective. Just the people that have signed it, and then the people that are actually sending data. So one of the parts of my job, obviously, I care about how we obviously want to be able to use the data to close care gaps and be able to help with care management and help actually push it to our members so they have a holistic member health record, be able to understand disparities in care, like understand like LGBTQ folks or like race, ethnicity type information. So great uses, and so I'm obviously very aligned to the vision and the mission, what we're trying to do. Like I would just wish it was like actually working at scale, right? Like but that said, though, I'm sort of glass half full always, right? I think I'm optimistic it exists. And as in every regulation, I feel like it's always off to a sort of a slow start, right? I go back to like, I don't know, meaningful use from 15 years or 10 years back. And it's just these things always start slowly. I hope it actually, more people jump on and we actually have the free flow of data happening, which would be great.
Yeah, I mean, I think there, as you probably know, Connecting for Better Health. Shout out to Timmy. They're working pretty hard to try and bring people together to move it forward. And there's some additional efforts with a follow-on bill that are happening right now, which could change some things from the state perspective. But at the end of the day, as Kat knows, you have to get all of these stakeholders to actually want to do this and be incentivized to do it, or like it's unlikely to make a real impact. As we're seeing, implementation takes a super long time.
Yeah. Also, it needs money.
Yeah, it needs money.
True. We've had, I must say, like we're like a founding member of Manifest Medics, HIE, and obviously we've had pretty good hospital adoption there. Prior to my job at Blue Shield California, I worked for Healthcare Service Corporation, HCSC, it's a large payer, Illinois. And so there I worked with Epic closely to help create the Epic Payer Platform, which is sort of vehicle by which we can exchange data between payers and providers. And Blue Shield of California also uses the Epic Payer Platform. It's good to see, since we're live at about 11 health systems now. We just started the work this year. And it's awesome, right? So where there is a will and there is aligned stakeholders, there is definitely a willingness to jump on and do this. And so we're exchanging data for quality and risk adjustment purposes. And then we'll hopefully be going live with pushing out care gaps in provider workflow as well. So again, a payer has information of care gaps. How do we sort of like help the provider see what the payer sees as well? So I'm excited for those. And so I think it was just where there is alignment. I think there's definitely it's cool to see these things happen, but I think to do this at scale, statewide or nationwide, I think there's needs to be more carrots, more stakes, more funding, more support, just all the things that make change happen.
Yeah. How do you, I mean, I realize you weren't personally responsible for the funding and the support of Manifest Medics, but how do you square the Manifest Medics investment? And I should say Manifest Medics is a member of Civitas, just to be clear. How do you square the investment in Manifest Medics with the investment in Epic's payer platform? Because in some cases, HIEs are serving in those roles of enabling some of those things. Obviously, Blue Shield is a massive company. You have lots going on and so many different segments and things like that you work on. But just curious, like how you think about the ecosystem of data exchange that a forward-thinking, technology-forward payer like Blue Shield is. Like, how do you think of the ecosystem?
Yeah, I mean, I think for me, our data exchange strategy is multi-pronged. Right? We want to I don't know if a singular solution is sort of the right answer, right path anyways. And so obviously we were founding members of Manifest Medics. We are super supportive of the role they play in our ecosystem and in the state of California. It's just wonderful to see them continue to sort of grow there as well. That said, we want multiple prongs. Manifest actually is our partner to help help us be compliant with the data exchange framework, and so they have a key role to play for us as well. What we've liked about Epic is just one, it's multi-pronged. It sort of gets us to providers like physician groups, others as well that are using Epic instances, not just the hospitals, which is the primary focus initially of Manifest there. And then more powerfully, I think that the ability to actually push out insights in workflow, I think is really cool and really unique. So it's been exciting for us to tap into, and having just a tighter integration with health systems that use Epic. And we have like 50 health systems in California that use Epic, and so it's a pretty large footprint. And so we wanted to meet our providers where they are, and of course make it easy to have them exchange data with us in a tighter, integrated sort of manner as well.
Yeah, I mean, I would certainly, I 100% agree that like data exchange is not likely to be solved by one strategy or one connection or one platform, one solution. But it's just interesting to think about with such a large and complex business that Blue Shield has, and the position in the state. Shout out to California, being as bigger than most countries. Thanks a lot.
In Canada.
Bigger than Canada, whatever. So there's a lot going on here. So that makes sense.
For sure, yeah.
Kat, you're back. Your internet, Georgia doesn't like the internet is all I can say.
I could hear you, but I couldn't see myself mostly. Yeah. So that was obviously a problem. Okay. So Krishna, Blue Shield's big. Y'all are not small. So what's the most disappointing business thing that happened to you in the past year? What was the worst? Because you're doing a lot of things, right? You got the Pride thing going on. You're doing lots of health equity stuff. You're also working with providers, network things. What was the worst thing that happened?
The worst stuff. I think the conversation we were just having, right? The data exchange stuff. I'm so excited that it exists, the framework, and I was I wish more people jumped on the thing and actually are sending data. That's the part where I would go it's not the worst thing that ever happened, but it's still it has such a promise of a better tomorrow. It's just I wish more people are on and sending data, because I do think there is there's just so much the system is fragmented, the healthcare system is fragmented. It has so much administrative burden for everybody, right? And data I think has such a powerful role to sort of really streamline just the basic, the information back and forth, and then of course using it for actually cool things like paying claims or prior authorizations or quality improvement. And so I don't know, it would have been such a cool foundation layer. I just wish more people jumped on and did it. Anyways, that was probably one disappointment for me for the year, but I'm obviously optimistic we'll get there. So.
Yeah, I mean, I would just I'll just put a double check on that one, because I did a little rant about this on Twitter at a very common cancer screening, and UCSF faxed the results to One Medical, and I was just guys, I mean, I actually had a moment when that happened, when I realized that UCSF had faxed the results to One Medical, is when I felt really sad, honestly. I was wow, it's a lot of years of my career that I've been working in interoperability and data exchange and health IT in general, to be in the situation where a business model can still sort of stop this stuff that's technically trivially easy, right? Where the standards are there, the networks are there. You just make a choice. You make a choice to press that eFax button versus trying to do whatever else you could do. And I got some interesting feedback on Twitter about it, oh, maybe because you self-referred. And I'm maybe, but doesn't really pan out for me.
It was your fault, Lisa.
It was my fault that I said fax only, please. I appreciate that people are that these companies are putting things in a wrapper. Of course I can see the document in my chart. Yes, I can see the document in my chart. Yes, I can see the fax document in Amazon One Medical's, patient portal as well. But that's just a wrapper. That's just a sort of very high, there's no need for that kind of stuff. And then today I also had a call with someone working in a disease registry specific space with some interesting grant funding. They're so is it technically possible for us to get electronic lab reports from different EHRs? I was dear Lord, it's 2024. Yeah. That's been possible for a real long time. And they're heart in the right place, asking the right questions. People from the outside are why can't I do this? And we're still asking those questions. And it's that's been in certified EHR technology for a real long time. There is no good reason that this would not be something that you could do. People just don't want to take that extra step or make it happen. Or where's the money? Where's the incentives? Stuff that you're seeing, Krishna.
Yeah. It's literally 20 years technology, right? It's there. It clearly exists. And it happens in pockets in our nation. So it's not even like some sort of like, secret pilot somewhere. Like this is real life.
Right. It's like really available right now. Like not a
Yeah.
secret pilot. Exactly.
Exactly. Yeah. I would say, yeah, your comment or your experience reminds me, like we've got our CEO, like his mission is like, I want to get rid of fax machines. We have to eliminate fax machines. And so I feel like healthcare keeps fax machines just like alive as an industry. And so it'll be good to get the point. I mean,
it is like the stickiest product in healthcare is the fact it has to be the fax machine. It's amazing. Yeah, we should all learn a little bit about the mighty fax machine and how it has ousted so many different good ideas. Yeah. Hey, Krishna, what's your favorite healthcare policy?
My favorite healthcare policy.
Tell me it's information blocking. You guys fine. You can pick whatever you want. It's fine.
I think I've appreciated just the evolution as I helped implement like meaningful use when it first came up. Like that journey has been good for me. Like we need the foundation of electronic health record, and then building on top with interoperability, adding the sort of layers of information blocking, and just some of the from the Affordable Care Act, like the value-based care, the innovation piece. Because I think it's personally close to my own mission, right? Which is how do you like aligned incentives. So value-based care needs sort of actionable analytics, and those two things are just like key to really transforming healthcare for me. And so policies that I've gravitated towards have been like things that promote interoperability, things that align incentives, like value-based care. Like so, those are things that sort of bubble up in my healthcare career. And there's potential, right? I'd love to see a world where we can use the data, use the incentives, ultimately to improve care, create more affordability, make health just more equitable. And I, particularly as a sort of a member of the LGBTQ community, like how do I make sure that care for people like me is equitable, is appropriate, is thoughtful, and there's a long way to go, right? Like just not even like, are there enough providers that can understand me? Are people like me even comfortable reporting things like sexual orientation in the data sort of pipelines to collect so that the providers and payers can even see it and actually like tailor their care and messaging to me? There's just so much to do as a healthcare system, particularly for marginalized communities and people of color. Like we have many, many miles to go. But obviously I'm just grateful for at least the layers of this sort of the layers of pizza that we're building on this process. So.
What do you think? I'm sorry, I'm like monopolizing all the questions here, Lisa. But like, I want to ask you two questions. One is like you're talking about like mistrust, right? Like, for marginalized communities, how do you even get the right data in because people are uncomfortable? The second question I have for you is like value-based care. Like, how do we actually get there? Because Lisa's former employer is all like, everybody's going to be in a value-based care model by blah blah blah. So I don't know how you want to answer this, but yeah. Look, I don't even know. We're gonna find out, Lisa. We have like an expert, like he's visionary. So, but yeah, like what do you think like the next step is in like solving for mistrust? And then yeah, like is value-based care even real? Like what?
Yeah, the mistrust. I mean, it's an issue we've encountered and had to solve for as well. Right? I think particularly with like, why do you ask me my race and why do you need ethnicity? Like, what are you gonna do with it? Why do you need my sexual orientation or gender identity? I think there's just like, what are you going to do with it? I think is the key sort of theme there. And we've done some surveys, our own employee resource groups, to understand like, hey, like what can we do to increase trust? And it comes down to us being clear on like the purpose of the data, like what do we plan to use. I think has helped us sort of build trust there. But I understand the mistrust too. Right? You've got like staggering statistics around like people in states that whether it's gender neutral bathrooms or like gender affirming care. There's a lot of laws and regulations, particularly around transgender care. It's very shocking. I can see why people don't want to trust the system because they've got every reason to not trust it. There's regulations being passed that are questioning their very being, and so I understand the reason for the mistrust. What we've seen, at least, is the more we can educate on the why and what are we trying to do with it, and why is the payer asking for this? Why is my employer asking for this? I think getting that, I think, is step one for me. And then step two, I mean, as with everything else in healthcare, like how do you integrate in the workflow, whether it's the providers collecting it. We've done pretty good, particularly as I think about the last sort of 15 years of meaningful use, like being able to collect things like race and ethnicity and language during the enrollment, during registration. So once it's baked into healthcare workflow, I feel like the data collection becomes sort of second nature. And I hope we get to that point with more sensitive topics like sexual orientation, gender identity that can help us sort of tailor care and messaging there. So anyways, that's my trust comment there. Value-based care is interesting. I think for me, I've done this for I think 15 years of my life, or maybe, yeah, or longer too. I think the biggest aha for me was like one person's value is another person's revenue, right? So it's like there's a natural tension built in.
Love it.
Yeah, so it's like as much as you have the purchasers and the regulators are like, we must do value-based care by XYZ year. Yeah, of course, they're sold. But you've got all the stakeholders of value which means reduced revenue. They're like, well, I don't know, I like value-based care as long as you focus on quality measures and care gaps and not actual cost reduction or so it's a little bit of there's a push-pull there. What I'm optimistic and positive about is just there are clearly new generations of care providers that are sort of building themselves from the value-based care up methodology. That is the way they are looking at payments and models, and not just maximizing, optimizing, and just a broken fee-for-service system. So I'm optimistic of that. But I think it's going to take a concerted effort of, particularly I see even in California, like Office of Healthcare Affordability, they're of course pushing on how do you make sure cost trends are kept low, how do you make sure penetration of value-based care. They're using sort of the sticks of regulation to further that along. So it's good to see movements like that combined with certainly regulators, whether it's Department of Managed Care or large purchasers like CalPERS or Public Employee Retirement Systems that are all leaning into value-based care, which is fantastic because we need more purchasers and groups like Purchasers Business Group on Health and regulators growing the boat in the same direction for this to become reality as opposed to a sort of a PowerPoint talking point, right? So anyways, that's my glass half full perspective, but my aha was just there's just tension. Everybody's not on board. And that's what we see play out, where it's taken us 10 plus years for adoption to grow.
Well, Lisa, without margin, there is no mission.
That's right. But also, increasingly the consensus around value-based care is that, we have not seen a lot of success in this latest push. We have a lot more work to do, but also, these offices of healthcare affordability and these commissions on global caps or caps in trends and spend in a particular state are really not going to get us the whole way there. And, prices of drugs, prices for services, those are the issues. And nobody wants to take that step to say no, we can't pay $3,000 for that MRI. We just can't. Yeah. We can't. It's the same MRI as the other one that's $500. We can't do it. And so that's where it really takes leadership. Shout out to my friend Dan O'Neill, who is constantly saying those things on Twitter, which I refuse to call X.
Yeah, well, I think
and in real life, he says it in real life too, not just on Twitter.
But back to medical mistrust, we have a comment here from the crowd, and I would agree. I too would not tell people things if this was how I was coded, right? That sucks. Yeah. High risk homosexual behavior just for being a gay man. Yeah.
Let's talk about the prohibition on donating blood for so long for men who have sex with men, and all of the sort of scientific stuff around that. So so many things, so many decades, centuries of just maltreatment and mistrust. It's not a surprise.
Not great. Not great. But Krishna, we gotta go talk about cancer care. So what would you like to leave all of our loyal fans with?
All 10 of them.
Depends on the day. Sometimes 7, sometimes 12.
One, I think that data is key for this. If you were to sort of get to marginalize, communities and population to get to care, I think, just getting the data and clearly creating frameworks and structures and incentives to collect good, thoughtful data is key. We've got to work on the trust. I mean, just like the comments was saying as well there. And so we've got to obviously, get people that are submitting data and sort of sharing very personal things about themselves to get comfortable that it's going to be used for good. And and the glass half full said, I think there are bright spots in all of these, and so I'm hopeful we will continue to shine a light in the bright spots, work that payers like us are doing in order to further these hard, complicated conversations forward, and work that regulators and others are doing as well to make this happen. So there's bright spots. I just want more people to join in this journey and make sure we can scale these bright spots to become something that's just that's nationwide as well.
Nice.
Hyper positive.
Thanks,
well,
Krishna.
it was a pleasure to meet you. Great. Thanks for telling us things. Thanks for handling us, and we will talk to you soon.
Sounds good. Have a wonderful time in Verona, Wisconsin. Get dressed up in the costume and tell good stories, and story is the theme, of course. And so enjoy, have a good time, and look forward to chatting again sometime.
Awesome.
Thanks, Krishna.
Well, we'll see you soon, and we will tell our stories live on the internet.
You will.
All right. All right. Okay. Next up, we have Dan Nardi, who is I think the CEO and co-founder, or I don't remember. He's going to tell us of Reimagine Care. Quick disclaimer. Everybody, I don't actually know who he is, but just a quick disclaimer, not that this is an unbiased show and anyone believes we're real media, but I'm an LP in Oncology Ventures, which is one of Reimagine Care's investors. So obviously I love this guy. I think he's the greatest and he's going to succeed, because if he doesn't, then I lose a bunch of money. So yay!
Look at that. Look at that COI. Look at her.
Boom, 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 boom.
Not a real journalist. That's all I'll say. But Dan, I'm sure you're great.
We appreciate the support. It's going great. It's Friday, and I appreciate you having me on. And the conversation's been great so far, and look forward to taking it from here.
Yeah. So Lisa, watch out. Dan emailed me. He's like, anything you want to talk about? And I was like, you better come up with something, or we're going to ask you questions. And so I don't know. I don't know.
Yeah. Tell us about Reimagine Care, Dan.
Yeah.
What easiest question?
All right. So what Reimagine Care? So what we are really focused on is supporting patients and their providers for going through the cancer treatment journey. And so we have built a suite of services that really help support them from proactive symptom management, medication management, all of that, and really helping patients through a really challenging time. Otherwise, the whole industry has been focused on a clinic-based model, and what we are doing is helping to lead that evolution into one that is supporting those patients outside the wall, meeting them where they want to be met, on the go and at home, and so they can spend more time with the people they love and not having to go back and forth for all their treatments. So that's what we're doing at the highest level, and obviously we can get in a ton of detail from there.
Nice.
So question. So a lot of times Lisa and I may or may not trash talk virtual care companies that focus on one specific condition. Is that in fact how we would classify you?
Yes, but I'm going to put a caveat on that. So what I would say is, the cancer is not just one condition, it's many. And so it is very broad. It is extremely variable across those. And that's one of the reasons I love the conversation you all were just having on the value-based care. Cancer care is actually even further behind the rest of healthcare on the transition to value-based care, because it is so variable. It is not just one disease. And so, yes, you can trash us all you want for being focused on cancer, but I think it is a much broader conversation.
I'm not going to, because you have my money.
Wow. No. And also, I would just say, to connect back to the last I bet you there's a lot of faxes in cancer care in any serious condition, chronic condition, otherwise. I'm sure it's just a fax heaven.
Yes. Yeah. Lots of data. Yeah. And one of the things as you all were talking about that value-based care, that's where the whole industry is going. And that's why I loved that conversation. What we need to be able to do is, how do we think about this from a cancer perspective, because it is so variable, because it's so different, working on building these new models, right? And what what can we put into bundles? What can't we? And what are the right avenues that we should all be working towards, from the provider perspective, from the payer perspective, and especially from the patient perspective, to tie it all together. That's one of these charges that we're leading right now.
Yeah. So how does it actually work? Tell us, you obviously can't get you cannot get all of your cancer care at home, because you often need procedures and imaging and all kinds of other things. So tell us about how you integrate that.
Absolutely. So what we do is we partner with health systems. We've got City of Hope, we've got Memorial Hermann, we've got independent community practices all across the country. And what we do is we become an extension of their care into that home, into that virtual setting. What we know is oncologists and their teams are really wonderful when you're there in person, when you're in front of them, you're in the clinic. What we're able to do is we partner with them. We actually, in most cases, we white label. We allow our partners the opportunity to either white label, we can use Reimagine Care. So we make an easier patient experience. But what we become basically a part of their team. And then we layer in our technology. So we have an AI-based virtual assistant that we combine with our team of oncology trained nurses and APPs. I see the squinting on AI. We'll come back to that. We combine all of that together, and we're then able to support those patients more outside of the clinic. That's what I mentioned earlier, kind of helping lead that evolution where it's not just the clinic, it's the clinic and, right? It's the clinic and the support at home, on the go, and getting those real-time answers at 2 a.m, when you're feeling really shitty. Like, that's the kind of support. So we're building that whole extension layer that a lot of systems and clinics can't currently do on their own right now. So.
Mm-hmm. Mm-hmm, mm-hmm. Yeah, I mean, I think, just generally, if you can manage, side effects of treatments, that's probably in and of itself a value exercise, because cancer treatment sucks and it is painful, and there are terrible side effects to things that are trying to kill just the bad cells, but leave the good ones, maybe. Lots of side effects there. So I would imagine that's a big part of the experience for someone going through cancer treatment.
That's exactly right. And so, the AI we talked about, right? So kind of we proactively were checking in with patients a couple of times a week, letting them know that they've got this resource, they've got this team available to them at any point. And so as they're going through that, they have their latest treatment, maybe Friday morning, like later in the afternoon, evening on Friday, they're starting to, have some of those symptoms, reactions. They interact with us. We're able to get them answers. If it escalates to a point where our team needs to take it over, we can take over that conversation in real time, in the moment. And then we're able to transition to a phone call or even a video visit as needed. So we're able to catch these symptoms at that lower acuity level before they escalate, to an 8 out of 10. And then all of a sudden someone's like, I got to go to the ER. Right. So coming back to the value-based arrangement, because we've got those interactions, those connections, that kind of in their moment opportunity to kind of build that acuity model on the fly, we are able to support patients. So, we talked about the value-based care, moving that, in the future, we're going to be able to kind of take that avoidable ED visit, outcome that we're already seeing right now because of our program. We're going to be able to build those models, those alternative payment models based on that. So.
Nice.
Well, okay. So I have 2 questions, but I'm gonna ask one. So, we might be biased because we're friends with Grace Cordovano / comma PhD, and she's always telling us about cancer stuff and how terrible it is. And I feel like cancer is like the number one example we have when people are like, I couldn't get my data. They sent me a CD, like blah, blah, blah. I had to coordinate with 25 different providers. Like, why is that? Is it just because it's like a high cost, like high acuity
I have a theory.
situation?
Can I say my
What's
theory
your theory?
first?
Yes,
and then Dan can tell.
obviously.
Okay, my theory is that there are a lot of specialists involved and they don't have the financial incentives to care about integration. What do you think, Dan?
I think that's absolutely part of it. And then also, like, your primary care may refer you to an oncologist, and they may be two totally different EHRs, right? So the conversation like Epic and all those other ones, like, do they really integrate? Do they not? I know you had a previous episode, you talked about, like, you could have both of them could have Epic, but in different systems, and you have different logins, and none of it shares. And so then you have, your imaging. Let's see, you need to get radiation or anything like that. Any of those images you're going to have, that might be in a totally different system. So I think because, at least is spot on, I think because you end up going through cancer care, you end up in a lot of different places, talking to a lot of different people. It's not centralized. And I think that's one of the biggest challenges.
Yeah. What I like about what you're cooking up is people treatment sucks, right? And there's a lot of things that can go wrong. And people otherwise, if they didn't have an easy outlet, you're not going to call a teledoc, I don't think, to be like, oh my God, I'm on this new medication and blah, blah, blah. But it does seem like it simplifies
You probably
access.
shouldn't. You're not likely to get a good quality of care for something that's so specialized.
Everybody knows, the only reason I call the teledoc is when I need pink eye drops for my kids, and then I call them and tell them I have pink eye, and they say yes, ma'am.
I'm gonna tell them, Kat, this is on the internet. You can't do that's illegal.
Listen, Lisa,
I'm going to turn you out. This is a citizen's
Do you know
arrest.
how hard it is to get
Yes.
pink eye drops? Like, what
Yes.
the hell?
That's why
Anyway,
I
the point
have a
is,
stash of Paxlovid in my. Oh shit! I said that out loud.
is that
Sorry.
also illegal? Oh my
Probably.
God. Yeah, I'm also. Anyway, I'm also hoarding all kinds of birth control because I live in a red state, so I might need it. I don't know. Anyway,
Oh,
Dan,
it's
sorry
fine.
about that. Sorry about that segue. Anyway, so that seems great. But like, are you still teaming with Dispatch Health? I saw that that you guys. So is that what happens? Like, if someone needs someone deployed to the home, you work with Dispatch.
Yeah.
Yes,
What
that's
happens?
exactly right. We have a great
Okay.
partnership with Dispatch. And so, early stages as we were building out the business, thinking about like, all right, what do we want to build by partner? Like, what do we want to own? And what we realized was like the actual final leg, like being able to go support the patient in the home. There were other companies that were already doing it really well. Dispatch is one of our national partners. We have, as we move into different states, if they're not in one, we have the opportunity to kind of work with others around there. But that's exactly right, Kat, is let's say, in that example I used earlier, Friday afternoon, interacting with the patient, realize, it's super dehydrated. Like maybe they could just benefit from some fluids, right? So we could actually send Dispatch out. They would go into the home, provide them some fluids, hang a bag, and then, help get them feeling better like late on a Friday and not have to go into urgent care and not have to go into an ER. And so those types of things. And so they've been a great partner for us as we've continued to grow and scale across the country.
What's the number one like type of call you get?
Ooh, that's a good question. Pain and nausea are probably the two most common
I was going to
ones.
say nausea for sure. It has to be. Yeah. Yikes.
Yeah.
That's the worst.
It really is. And when we think about these, a lot of the symptoms, we built out these symptom pathways with our virtual assistant. A lot of these were actually able to support the patient just with the technology, right? So as they're interacting and responding, we're kind of asking follow-up questions. We're kind of building those real-time like acuity models on the fly. But a lot of the times just giving them some suggestions using these NCCN guidelines and the pathways we built out, 48% of all of our interactions are resolved just through the technology, not even having to have, one of our care team members take over the conversation. So it kind of goes back to like, why does this scale? Like, why is this like something that we can do and clinics aren't going to be able to do as well? Is because the combination of all of this allows us to do it way more effectively, way more efficiently, from a cost perspective.
So in your remaining few moments, tell us why AI isn't dumb. You know that was coming.
I know, I figured it was. So I think, and to be totally fair, right, like it has a huge potential. I think right now we're just scratching the surface, all of us. We're all just figuring out like what this can do. That's I think one of the exciting parts. So Christian had like his exciting kind of moment, what he's looking forward to. I think from an AI perspective, like, could you imagine in the future where like as you're interacting with this type of solution, let's say Reimagine Care, ours right now is a little bit more rules-based engine and obviously, natural language processing and everything else. But like, wouldn't it be great in the future if it like kind of knows all my historical data, plus it's building that real-time acuity model and it's actually able to like figure things out on the fly and give me more of like a real interactive response and not as like I'm answering it the same way and I get the same response every single time. So, I think there is a huge potential, Lisa, but, at the moment we're still, I don't know if we're even in the toddler stages, if we think about it from that, like we're still early on. So yeah, right now it feels like it's still bumping into walls and figuring itself out, but there's a huge potential.
Honking in the parking lot.
We actually have a really honking at each other. We have actually a real like thoughtful question from one of our loyal listeners, watchers, from Jim Nazar.
It's from Jim. Yeah, just so everybody knows, we can't see who's posting unless you make it so you're following us or something. So LinkedIn user, apparently Jim Nasser, has this question for you.
Considered ways to run federated searches on decentralized cancer data, validated data sources.
So this guy sounds like a nerd. Jim is a nerd, clearly, like into it.
Basically, like you're in the position to be able to access and use for legitimate purposes only a lot of different types of cancer data from a lot of different patients. Like, are you thinking about the research use cases or the ability to use, this in a safe way, not to imply that you would use people's data in a way that is not safe or allowable by law or with their permission? So
yeah. 100%. And so this is something we've realized that we do have a very unique data set, right? Through our partnerships with all of our health system clients and practices clients, like we've got that historical data, right? That's in the EMRs and the prescriptions through Surescripts and everything else. But then we're building those real-time symptom models. So we know what your diagnosis is, we know the medication you're on, and then we can tell all those symptoms. And so you think about this with thousands upon thousands of patients, it's building a really unique data set. So to Jim's question, like we are being really, really careful with how we think about using this moving forward. And knowing that it is a very powerful data set that we're going to be able to kind of collectively use to be better, but we're not just diving headfirst into it. We want to make sure we're being really thoughtful, that we're using it within the right, parameters that we can use it in, but also then ethically make sure we're using it the right way moving forward. So
I'm hearing
it's
a
a great
not
question.
yet I'm going to interpret you to say not yet. They're thinking about it. This is not Dan. This is Lisa speaking, just to be clear. I'm not actually speaking for Reimagining Care. So thinking about it, stay in touch because this is an opportunity in the future for maybe
Dan will
better
be back
cancer
next
data.
year.
Next year to talk about
I
their
hope I am,
data
and then
model.
we can like have a real world example of how that played out. So
Amazing.
Oh, okay, Dan. Last thing before we go, drink some wine because it's Friday. In a year, because you'll have you back on the show. What is the big thing that you're going to accomplish in cancer care in the next year?
yeah.
Ooh.
Yeah, I think there's a couple big things. I'm going to go. There's one of them is continuing to grow our network, which is going to be huge, right? So we've got a bunch of really great partners, NCI designated cancer centers around the country. Continue to grow that footprint, and then really starting to say like, okay, how do we now use this to evaluate the move into value-based care? How do we start to say like, all right, we need to be working with the payers and figuring this out together. So how do we work with our amazing provider partners and then collectively go to the payers and say, all right, now let's figure this out. We've got all the years of data now.
Nice.
Like, let's go move this forward. So I think that's a big one. Like I said earlier, we want to be leading this charge into value-based cancer care. And, there's huge opportunity to kind of shape how this plays out.
That's a awesome. Cool goal.
Yeah, I like it.
Well done.
Ambitious.
Yeah. Oh my God. Love it. All right. Well, Dan, thank you for joining us. Thank you for handling this. I feel like both you and Krishna handled this very well.
Loved it. Thank you for having me.
Just before we go, Michael Marchand says Jim Nasser is an exceptional nerd. And then Jim concurs he is a nerd. And then also, Michael, I was not saying that with any sort of disdain. So anyway, that's totally fine. But thank you, Dan. Thanks, you're awesome. Dan. And, hey, congratulations on graduating from the Cancer X Accelerator. I think that was you.
We just did. Yep, we officially first cohort.
Congratulations. That event had wine at it. I wasn't always totally paying attention, but congratulations. And yeah, we'll have you on in a year to see if you've totally transformed value-based care for cancer care.
Nice.
Awesome. Appreciate it.
Thanks, Dan.
Have a good Friday.
All right. Thanks, y'all. Happy Friday.